On today's lesson, we are digging up in tracheostomy procedure, which is one of the oldest described surgical interventions. There are multiple indications for such procedure. It can be used as a solution for upper airway obstructions of multiple etiology. First of all, the neck is placed in extended position. The skin is prepared with antiseptic solution and appropriate surgical drapes are placed maintaining sterility. The steroid notch, the lower part of cricoid cartilage, and suprasternal notch are marked. The tracheostomy incisions marked as a transverse line placed halfway between them. And infiltration and local anesthetic mixed with adrenaline solution can be applied after these landmarks are known. Incisions through skin and dissections through subcutaneous tissues performed. Strap muscles identified and divided vertically in the midline. Care is taken not to damage the anterior jugular veins that usually lie slightly more lateral on either side of midline. Identification of ceroid isthmus is carried out. One should identify any large vessels, especially ceroid veins, that are usually placed at the inferior border of the isthmus. Hemostasis and dissection of isthmus are achieved with bipolar diathermy. Exposure of the trachea by blunt dissection. Deeper retractors are placed for adequate visualization of each side. Tracheotomy window created at the level of third and first tracheal rings. The incision area is marked with bipolar after confirming the position of the cricoid cartilage and counting of the tracheal rings. The width of tracheotomy window should never exceed a third of diameter of trachea, and generally one should be as conservative as possible. If a window is created, a maximum of 2 tracheal rings are partially excised. This step is done with sharp dissection using a blade 15 knife. Care is taken not to damage the underlying endotracheal tube. The tracheotomy window is secured and controlled either with tracheal dilators or with a blunt cricoid hook. The tip of the tube and trachea is lubricated with a water-based gel, and the tube is inserted gently from a lateral position. The final correct position of the tracheostomy tube is attained. The cuff is inflated with air and inner tube is inserted if needed. A sterile connector is used to connect the tracheostomy tube with an anesthetic machine. Skin incision is closed loosely if necessary. The tracheostomy tube is secured in a position with sutures, and the connectors is ensured to be in a neutral position and not to pulling on the tracheostomy tube. Although there are many variations in performing a classical open surgical tracheostomy, these are all based on a starter technique composed of few fundamental steps, a safe procedure in experienced hands or where there is adequate supervision.